Antibiotics are precise agents deployed against exact microscopic targets. We select these drugs based on the anatomical vulnerabilities they exploit within a pathogen. This targeted kinetic action follows two distinct pathways. The first of these is bactericidal action. A bactericidal drug kills the organism. It forces a physical failure that ruptures the bacterial cell, eliminating the pathogen through outright structural destruction. The second pathway is bacteriostatic action. Instead of destroying the cell, the drug locks the bacteria's growth and replication in place. The pathogen remains intact but anchored, allowing the host's own immune system to clear the infection. Distinguishing between these kinetic outcomes, whether a drug shatters a cell or merely stalls it, is the foundation for choosing the correct therapy. To understand how these drugs achieve their effects, we use the structural map of the bacterial cell. This 3D model identifies the three primary targets for antimicrobial assault. The first target is the outermost protective layer, the cell wall. The second target lies deeper within the cytoplasm, the ribosomes. These are the protein manufacturing centers that drive the cell's metabolism. The third target is the nucleoid at the core of the cell, where the bacteria synthesizes its DNA and the folic acid required for replication. Every antibiotic class used in modern medicine operates by disrupting one of these three anatomical zones. Bacterial cell walls rely on a rigid grid of peptidoglycan chains for strength. This grid is actively cross-linked and stitched together by specialized transpeptidase enzymes. Beta-lactam antibiotics are defined by a core chemical ring. This ring inserts itself into the transpeptidase enzymes, which jams their movement and immediately stops the construction of the peptidoglycan grid. Without active cross-linking, the wall quickly weakens. The internal pressure of the cell causes the compromised structure to fail, and the bacteria shatters in a bactericidal lysis. Penicillins, the class first discovered by Alexander Fleming, represent the foundational beta-lactams. Drugs like amoxicillin remain the primary tools for treating common sinus and throat infections. Cephalosporins, like ceftriaxone, utilize this same mechanism across multiple drug generations. This development broadened their efficacy from gram-positive bacteria to include highly resistant gram-negative strains. For life-threatening cases of meningitis or severe sepsis, clinicians deploy the heavy hitters, carbapenems and monobactams. These classes are reserved for pathogens that have developed resistance to earlier beta-lactams. While their clinical uses vary, all beta-lactams share this core ring structure and result in a bactericidal outcome. Bacteria have developed a counterattack, the secretion of the beta-lactamase enzyme. This enzyme is designed to find and snap the antibiotic's chemical ring before it can ever reach the cell wall. To bypass this defense, we deploy combination therapies. We pair a primary beta-lactam with a beta-lactamase inhibitor, such as clavulanate. This inhibitor acts as a molecular decoy. It neutralizes the rogue bacterial enzyme, allowing the primary antibiotic to reach the wall and complete its assault. For pathogens like MRSA that are highly resistant to these rings, we turn to the non-lactam structural inhibitors, specifically the glycopeptide class, which includes vancomycin. Vancomycin bypasses the beta-lactamase enzyme by using a physical blockade. It acts as a massive cap that binds directly to the peptide precursors, preventing them from ever connecting to the cell wall grid.
Effectively breaking the cell wall requires this constant evolution of drug design to stay ahead of bacterial adaptation. Inside the cell, the protein manufacturing centers, the ribosomes, are split into two distinct subunits, the 30S lower half and 50S upper half. Inhibiting these ribosomes is a bacteriostatic action. By shutting down the assembly line, we deprive the bacteria of the proteins it needs to function and replicate. Aminoglycosides, including gentamicin and amikacin, bind specifically to the 30S subunit. This binding causes the ribosome to misread the messenger RNA code, creating defective proteins. This makes aminoglycosides highly effective against aerobic gram-negative bacteria during cases of sepsis. Tetracyclines, recognizable by their suffix in drugs like doxycycline, also target the 30S subunit, but use a mechanical block. Tetracyclines physically block the tRNA from attaching to the mRNA complex. By halting this protein synthesis chain, they become the preferred treatment for many respiratory and rickettsial infections. By attacking the 30S subunit, These drugs stall the bacterial machinery and prevent the infection from spreading. The upper half of the ribosome, the 50S subunit, serves as the target for our next class of inhibitors. This is the domain of the macrolides. This class includes widely used drugs like erythromycin, azithromycin, and clarithromycin. Macrolides bind to the 50S subunit to inhibit the translocation step of protein synthesis. This mechanically jams the mRNA strand, so it cannot advance through the ribosome to continue assembly. This makes macrolides effective against strep throat, bronchial infections, and H. pylori. Whether targeting the 30S or 50S subunits, these metabolic blockades turn aggressive pathogens into stationary targets for the patient's immune system. At the core of the cell, we reach the final battleground. On the left, the machinery of DNA replication. On the right, the chemical pipeline for folate synthesis that fuels it. Fluoroquinolones, such as ciprofloxacin and levofloxacin, are aggressive, bactericidal disruptors of nucleic acids. They utilize a dual targeting mechanism that jams the DNA gyrase and topoisomerase 4 enzymes. By locking the machinery that unwinds the genetic code, they halt DNA replication instantly. To disrupt the metabolic side of the nucleoid, we use sulfonamides like sulfamethoxazole. Sulfonamides act as bacteriostatic agents. They inhibit the dihydropteroate synthase enzyme, which severs the pipeline for folate production and starves the cell of the precursors it needs to form DNA. This gives clinicians a strategic choice at the nucleoid level: physically shatter the replication machinery or starve the cell of its chemical fuel. Looking at the bacterial cell as a whole, we see three distinct pharmacological battlegrounds: the cell wall, the ribosomes, and the nucleoid. This clinical matrix maps every antibiotic class directly to these anatomical vulnerabilities. Because we know exactly where a drug binds, we can predict its kinetic action. A drug that targets the cell wall or DNA gears will be a bactericidal killer, while a drug that jams a ribosome or a chemical pipeline will be a bacteriostatic inhibitor. This logical framework turns a complex list of medications into a predictable system. You no longer need to rely on the memory of a name when you can derive the effect from the mechanism itself. Internalizing this taxonomy provides the essential bedrock for modern clinical decision-making and responsible antimicrobial stewardship.